It's Dr. Rodney McCaskill recording a lecture for Johnston County EMS, March 2017. This lecture will be on sepsis. Here is the protocol for sepsis. As you can see in the center there, if you have suspected infection, plus any of the Sears criteria listed there, heart rate greater than 90, respiratory rate greater than 20, GCS less than 15, temperature elevation or low temperature, as well as low blood pressure, then you need to go ahead and give the patient a fluid bolus. And we'll talk more about the reasons for that shortly. Let's first start with the scenario. Fairly typical situation where you're dispatched to a long-term nursing facility for a medical illness. When you arrive, you find a 76-year-old named Gerald. Unfortunately, he's nonverbal and minimally responsive. Had a stroke a couple years ago, has a feeding tube, an indwelling Foley. The nurse states he normally opens his eyes when his name's called, but doesn't usually do a whole lot else. He's had a fever of 101 degrees. Your partner goes ahead and starts with oxygen and obtaining vital signs. You notice that when you do your cursory exam that he has an ostomy site where the feeding tube exits, and it is red, swollen, with some purulent discharge around the tube. The urine in the Foley catheter and in the bag is dark and thick with a lot of sediment. What would you expect that his heart rate would be? Would you expect his heart rate to be elevated or decreased? I think for the most part you'd expect it to be elevated, but doesn't have to be. Respiratory rate, elevated or decreased. Again, you'd expect it to be increased, but doesn't have to be. Blood pressure high or low? Well, it all depends. I mean, if he's normally hypertensive, it may be elevated. If he's in septic shock, it may be low. And his O2 sat may well be normal. So before we talk much more about the scenario, let's kind of consider a few points here. First, in this lecture, we'll talk about the definition of sepsis and shock. We'll talk briefly about different types of shock, the pathophysiology of sepsis, what Sears criteria are, and briefly talk about a SOFA score. So why do we really care about sepsis? Why are we talking about this today? Well, this is a fairly old slide. This is back in 2001. At that time, there were, almost 1 million cases of severe sepsis per year in the U.S., and they anticipated it would increase by about 1.5% per year as the population ages. So incidence is similar to heart failure. Mortality is similar to acute MI. And that's another reason why it's important. So how long do folks with different conditions stay in the hospital? Well, these graphs kind of compare the difference in duration of hospitalization of sepsis to hospitalizations for other reasons. And you can see here by the graphs that if you're hospitalized for sepsis, your length of stay is about twice what it is for other conditions. And this involves all ages, but it's especially prominent in folks greater than 65. So, by our previous slides, you notice that sepsis is common and it's increasing as the population ages. It's associated with high risk of death, long length of hospital stay. Because of that, it's expensive. Most importantly, we can make a difference. Here is a more recent study from 2010 that showed what we can do here to make a difference with sepsis. The left side of the slide there shows hospital mortality. And what happened here is they initiated an aggressive treatment plan for sepsis. And they've graphed their mortality by quarter. And as you can see, as they became more effective in their aggressive treatment plan, the mortality dropped from about 37% down to 32, 31%. So, 5-6% decrease in mortality just by changing their treatment plan. That's pretty important to note. So let's start with, what is sepsis? So sepsis is a life-threatening condition, and it arises when the body has sort of an over-response or a maladaptive response to infection. This maladaptive response causes injury to itself. The body basically injures its own tissues and organs. How does this happen? So you have an imbalanced or unbalanced immune reaction to infection. This leads to lots of mediators, but the bottom line is you end up with microvascular thrombosis, which obviously is bad, vasodilation, and capillary leak. So you can kind of imagine what would happen here. You get, clotting of small blood vessels, you get dilated blood vessels, and you get swollen up from capillary leak. So this would typically lead to low blood pressure if it continues for a length of time. So what happens here is you get an infection that leads to an excessive host response. Mediators are released that lead to cellular damage. Damage to cells lead to organ damage. Enough organ damage ultimately leads to death. Severe sepsis is simply defined as sepsis that leads to poor organ perfusion due to insufficient, you could say, blood flow, insufficient oxygenation. You may get low blood pressure, altered mental status, poor capillary refill, high blood lactate, and you might even get decreased urine output. So all those are possible things you may see with severe sepsis. So let's start by defining what is shock. Shock is, at a cellular level or organ level, inadequate organ perfusion. It's not really defined as simply low blood pressure, but has to do with perfusion at the cellular organ level. With normal perfusion, this is the left side of the graph here, you get, glucose combines with oxygen, goes through the Krebs cycle, you get carbon dioxide and energy. So that's the way things normally work out. Normal pH, normal end-tidal CO2, that sort of thing. In a situation where you have poor perfusion at the cellular level, that essentially means you don't provide enough oxygen at the cellular level. In that state, instead of going through the Krebs cycle, your body uses lactate dehydrogenase to make lactic acid and a small amount of energy. So you get elevated lactic acid, you get acidosis, and you end up with low end-tidal CO2. And you don't make much energy with that side of the cycle either. So septic shock is poor organ perfusion due to sepsis that doesn't improve once you've given reasonable amounts of intravenous fluid. So there's lots of different types of shock. Our focus here is on septic shock. Here are the mechanisms of shock, sort of what leads you down to poor tissue organ perfusion. Sepsis is more of a distributive type of shock, so that's on the right side. You get a combination of myocardial depression, so your heart doesn't work quite as well. You get dilated blood vessels, that leads to decreased systemic vascular resistance. So you may actually see some increased cardiac output, but you get poor perfusion at the tissue level. Basically, it's a maldistribution of flow. It's important to remember that some shock patients don't become hypotensive because, again, shock isn't defined as low blood pressure. It's defined as poor perfusion at the tissue or cellular level. Some patients don't become tachycardic, especially if you consider those on beta blockers. Some patients will have fairly normal vital signs. So again, shock is not tachycardia, it's not hypotension, it's inadequate organ or tissue perfusion. Now if you go back to our case of Gerald, the nursing home patient, does Gerald have to have low blood pressure to be in shock? Of course the answer is no. The blood pressure, you certainly can have low blood pressure and be in shock, but shock is, again, poor tissue perfusion, which isn't necessarily related to blood pressure. Does he have to be tachycardic to be in shock? Again, doesn't have to be tachycardic. Can he have normal vital signs and be in shock? Absolutely. So you should not equate blood pressure and cardiac output. You should not rule out shock because blood pressure is normal. Again, to hit this for probably the fifth time, shock is inadequate perfusion, and certainly that it can occur with normal blood pressure. Sears. So a little bit of comedy here. Is that what we say in the South? Is it two or more gentlemen? Sears is simply defined as systemic inflammatory response syndrome. So it can be the body's response to infection or inflammation or some other type of stress. It doesn't have to be reaction to infection only. We use these definitions of elevated blood pressure, elevated temperature greater than 100.4, temperature less than 96.8, respiratory rate greater than 20, heart rate greater than 90, end-tidal less than 25, or lactate greater than 4. So Sears is the part we're talking about, at least has to do with infection related conditions. You can have Sears or meet Sears criteria if you have pancreatitis or post-trauma or with significant burns. So you don't have to be infected if you're Sears positive, but that's really what we're dealing with with today's lecture. And that's the screening tool that we use, emergency departments, EMS, to find patients that are at risk for severe sepsis. In the hospital, they may use something called the Q-SOFA score or the Sepsis 3 consensus definition for sepsis. I only mention those here so that if you see those in your personal reviews, reading papers and so forth, just so you know what those are. So those are basically screening tools for sepsis that are used in the hospital. They have to do more with how your creatinine changes over time, how your liver functions change over time, maybe what your ejection fraction does over time. Those are sort of they're looking at organ damage from sepsis, which those are things we can't really monitor from the emergency department or by EMS. When you define, when we talk about sepsis is essentially Sears criteria plus suspected or confirmed infection. Severe sepsis is sepsis plus at least one sign of organ hypoperfusion or dysfunction. With severe sepsis, you may see tissue hypoxia and inadequate organ perfusion. This leads to a metabolic acidosis and elevated blood lactate levels. In response to the acidosis, you start breathing faster and you end up having decreased levels of end-tidal CO2. And we can easily measure that using capnography. Septic shock is severe sepsis plus low blood pressure or low mean arterial pressure, less than 60. Need for pressors to maintain blood pressure despite fluid resuscitation. Lactate greater than 4, low end-tidal CO2. So how does end-tidal CO2 fit? Well, let's start by talking about cellular metabolism. Remember before we talked about normal metabolism, glucose goes through the Krebs cycle, you get CO2 and energy. The pH is normal, end-tidal CO2 is normal. When perfusion is poor, that means you get not enough oxygen to tissues. Glucose is metabolized using lactate dehydrogenase that leads to lactic acid and a small amount of energy. So you become acidotic, you breathe faster to try to blow off this acid, and you end up with a low end-tidal CO2. And this sort of talks about the same sort of situation that we just described. And again, this is more cellular metabolism. So we measure end-tidal easily in the back of the truck using our capnography. End-tidal, in the past, we've talked about it being related to basal metabolic rate, cardiac output, and ventilation. You can have abnormal levels when you have problems with perfusion, metabolism, and or gas exchange. In severe sepsis, you get poor perfusion that leads to elevated serum lactate and metabolic acidosis. We've touched on this briefly already, but the big question is, why does end-tidal CO2 decline when you're in septic shock? Well, again, like I said, we talked about this already. You compensate by your acidosis by breathing more rapid. When you breathe more rapid, you blow off carbon dioxide, and so your end-tidal CO2 becomes lower. The reason for this is poor tissue perfusion. Don't deliver enough oxygen to your cells, so you have to go through lactate dehydrogenase to metabolize glucose, which makes lactic acid. When you're acidotic, you breathe faster, blow off your end-tidal CO2. And so you get a low end-tidal CO2. We can measure either lactate or end-tidal CO2 in the back of an ambulance. Lactate can be measured by a device that looks like a glucometer. We don't have those currently in our county, but end-tidal CO2 we easily measure, and it's very accurate as well. Lactate is a marker for cellular hypoxia. In folks who have a lactate greater than 4, that's equal to a 27% mortality rate. When your lactate's fairly low, less than 2.5, fairly low mortality rate, less than 5%. That's why it's important. And again, I think we've talked about this already. Lactate also becomes elevated as a stress response. When your body releases epinephrine and so forth by stress, adrenaline, then it increases glucose metabolism and will increase your lactate as well. When your catecholamines are high, your lactate's going to be high, so it's a measure of the type of stress the body's under. The higher the lactate, the higher the stress the body's under. At least initially, patients can have fairly deceptively reassuring vital signs because of their ability to release epinephrine, adrenaline, etc. The effects of catecholamines would be to increase blood pressure by vasoconstriction. So at least the initial signs, the initial infection, sepsis, you might not see a big change in heart rate and blood pressure. But lactate levels should start to increase fairly rapidly as patients begin to decompensate. Again, same slide as before. Lactate greater than 4, 27% mortality rate, less than 2.5, less than 5% mortality rate. We use it in the emergency department. It gives us some idea of the patient's situation, at least at a cellular level. Here's an example of a machine that you can use to measure lactic acid at the bedside. Could be used by EMS, could be used in the emergency department. Again, let's talk a little bit about end-tidal. End-tidal CO2 is inversely proportional to lactate. What does that mean? That means that as your lactate level goes up, your end-tidal CO2 goes down. As the lactate levels rise in septic patients, end-tidal CO2 levels drop. Here it is in a graph. We measure end-tidal. The higher the end-tidal is, the lower the lactate is. The lower the end-tidal is, the higher the lactate is. So if you get a low end-tidal, you expect the lactate level to be pretty high. What can we do? What can EMS do? Here here's a summary of several trials. If you take a look there at the blue arrow, this talks about the specific interventions done in septic patients. So if you take a look, starting with Rivers, the interventions were fluids, blood pressors. The next trial was antibiotics, fluid pressors. Next trial, antibiotic, fluid, blood pressors. Next trial, antibiotic, fluid, pressors, steroids, Zygris, other, and the next. But if you take a look, the common thread in all these is fluids, 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 fluids. And if you take a look here with these specific interventions, The last column here talks about the absolute change in mortality. So with these interventions, you had a 16% drop in mortality. With these interventions, you had 12%, 19%, 16%, 7%. So pretty substantial decrease in mortality. And one of the common threads you'll notice here is fluids. Just so you know what we're doing at Johnston UNC Health for sepsis. Well, if we have Sears criteria plus suspected infection in the emergency department, then the patient gets blood cultures, IV fluid, a lactate level, IV antibiotics. If the lactate's greater than 4, or there's signs of organ hypoperfusion, such as new elevated creatinine, new elevated liver functions, then the patient gets a normal saline bolus at 30 milligrams per kilogram. And then we repeat the lactate level to make sure it's coming down. What can EMS do? Well, try to identify sepsis early so that in the hospital the patient's septic care can begin earlier. And then EMS can obviously do fluid resuscitation. Our goal is to give enough fluid to maximize patient stroke volume. We start with a 500 milliliter bolus. What's the goal? Well, the goal is to at least get the patient's blood pressure back to normal, but the real goal is to try to improve perfusion at the cellular and tissue level. If we have to give pressors, then we want to raise the mean arterial pressure enough to maintain intra-organ perfusion as well. So let's do a little review. The symptoms, signs and symptoms of sepsis in adult patients include fever or potentially low temperature, hypothermia, increased heart rate, increased respiratory rate, altered mental status, prolonged capillary refill. You need to think sepsis if you see any of these symptoms. A few other symptoms you may notice would be, mottled skin, capillary refill greater than 3 seconds. In the hospital, we may notice, urine output less than 0.5 cc's per kilogram per hour, a lactate greater than 2, abnormal mental status. If you're not perfusing your heart well, you may get an abnormal EKG. You may see DIC once the patient's been septic for a bit. And DIC is abnormal clotting and bleeding, kind of a combination of both. In an immune-compromised patient, this would include patients that are, severely diabetic, folks with transplants, folks on steroids. You might not see a whole lot of an immune response. And again, this would include the extremes of age. Infants may not show a lot of symptoms, and folks that are very old may not show a lot of symptoms either. The temperature may be normal, it may be low. And this is, again, talking about the initial presenting symptoms. Maybe, just feel bad. So to continue our review, SEERS is systemic inflammatory response syndrome, temperature greater than 38 degrees Celsius or less than 36, heart rate greater than 90, respiratory rate greater than 20, a blood CO2 less than 32, white blood cell count greater than 12 or less than 4, bands greater than 10%. 2 out of these 4 criteria or an acute change. Sepsis is Sears criteria plus infection. Severe sepsis means you have organ dysfunction. That would include, hypoperfusion, hypotension, acute lung injury, acute mental status change, acute kidney injury, coagulopathy, lactate greater than 4. Septic shock is severe sepsis plus hypotension, low MAP. Remember that sepsis is a continuum. You start with Sears criteria plus infection. If it progresses down the pathway, you end up with severe sepsis, which is sepsis plus in-organ damage. If that's not treated, you go to septic shock, which is severe sepsis plus hypotension. So Sears is simply the systemic inflammatory response syndrome. Shock is inadequate organ or tissue perfusion. You should not equate blood pressure with cardiac output. You should not equate blood pressure with organ perfusion. And then in the hospital, we may use a SOFA score. That's a little bit better than using Sears criteria, but obviously that has to do with a change over time, which we don't have the luxury of time when we're dealing with a patient by EMS or in the emergency department. There are a few cases here to review, sort of at your leisure, specific patients with sepsis. If we go ahead and skip to case number 2, you'll see this patient's initial temperature 99, heart rate's 103, blood pressure 87/55, O2 sats low, respiratory rate 20. So Sears criteria are met by the vital signs. It's an 80-year-old patient who is in the emergency department with cough, sputum production, generalized weakness, seen at urgent care the day before. Under review of systems, you got fever, cough, and shortness of breath. Here's your physical exam. Decision making, possible pneumonia, abnormal vital signs, borderline hypotension. Will obtain a septic workup. Chest X-ray shows right upper lobe pneumonia, white blood cell counts elevated, lactic acid slightly elevated. Patient got IV antibiotics and fluids in the emergency department. Here are the labs. If you notice here, you've got signs of organ damage, end organ damage, so BU and creatinine are elevated. That's what's those are the sign of that's the sign of poor organ perfusion. So you would call this septic shock if it's new, or severe sepsis. White blood cell counts elevated. Liver functions are normal. That'd be another thing we'd look at for signs of in-organ damage. Lactic acid is 2.5, so not greater than 4, but higher than the normal range here. So if we saw this patient by EMS, then certainly we could give them an IV fluid bolus, call the emergency department, tell them we have a potentially septic patient here. In the emergency department, the patient's going to get blood cultures, appropriate IV antibiotics, admission to the hospital. Here's another case. Patient here, you can see vital signs here, maximum temperature 100.5 in the emergency department. All heart rate recordings are elevated, although it does sort of trend down over time. Blood pressure is actually elevated and becomes normal over time. Respiratory rate fairly normal, O2 sat normal. So here's the chief complaint here. Head hurts, belly hurts, right foot swollen, smells bad. So this might not be a case you'd initially think sepsis. Head hurts, belly hurts, right foot abnormal. So this is a young person too, 27-year-old. History of diabetes, hypertension. The physician here kind of focuses in on the foot right away. Right foot pain, smells bad, warm, tender, some headache, some low-grade fever, belly pain. So again, the review of systems here, low-grade fever for ENT, congestion, sore throat. You saw the abdominal pain part in the history, and then the foot is discussed in the history as well. Here's the exam down at the bottom. For the extremity, you see warm, red, swollen right foot up to the ankle. Here are the labs. So kidney function looks pretty good. Liver functions okay. White count elevated. Lactate slightly elevated. And then on blood gas, patient's pH is 7.4. CO2 is low though, at 31. So this is a patient with obviously diabetes and a foot ulcer and cellulitis. What can be done for this particular patient? Well, certainly we can give IV fluids. we can call the emergency department ahead of time and say, hey, the patient's foot looks infected, heart rate's quite elevated, they've got a low-grade fever, concerned about possible sepsis. In the emergency department, we give IV antibiotics, obtain a lactate level, and get the patient admitted. Okay, this concludes the lecture on sepsis. It's Dr. Rodney McCaskill. This lecture is for Johnson County EMS, and it is going to be centered around EKG interpretation. So when we talk about an EKG is actually a picture of the electrical conduction of the heart. By looking at an EKG and recognizing abnormal patterns, we can identify many different disease states. The standard EKG has 12 leads. 6 of the leads are limb leads, and the other 6 are precordial leads. Each lead is looking at an electrical vector through the heart. If the vector is predominantly headed towards the lead, then it gives you a net positive deflection in the lead. So just to try to make that a little bit clearer, if the electrical pathway for the most part is headed towards lead 2, then lead 2 is going to be predominantly positive. If the main vector is headed towards AVL, then AVL is going to be predominantly positive. And here's an example of a normal EKG. When we talk about EKGs, we generally look at the P wave, QRS complex, and the T wave. And here's sort of a graphical of each of those. The P wave is the first part of the EKG, and the P wave starts here and ends here. Then you have a brief return to the baseline, and we talk about a baseline. This is the baseline, followed by the P wave, back to the baseline. Baseline here starts at the end of the P wave and starts back or changes at either the Q wave or the R wave. So this interval here is the PQ or PR interval. This particular strip has a Q wave, which is a downward deflection, followed by an R wave and an S wave. After the S wave, there's a brief return back to baseline. The interval between the S and the T wave is called the ST segment. You then have a T wave, which is followed by return back to baseline. There's a couple different ways that we interpret EKGs. One is by pattern recognition, and the other is by electrical vectors. We're going to talk about both because sometimes pattern recognition by itself is not sufficient. Here is a picture of the cardiac conduction system. And what I mean by that basically is it's the electrical pathway through the heart. The heartbeat starts at the SA node, which is here, and the electricity, once it's generated in the SA node, will fan out through the atria, which depicted here by these arrows. It will pause briefly as it enters the AV node. Once it enters the AV node, it will go down through the bundle branches located in the septum of the heart and then depolarize the ventricles. So it starts in the upper right of the heart and extends down to the left. It's kind of the general pathway of the depolarization through the heart. And again, if we focus down here at the bottom, you get atrial excitation, which is electricity fanning out, starting at the SA node and fanning out through the atrium. Atria then contract. Atria then relax. The electricity is sort of paused briefly in the AV node during this process, and then it continues to spread down through the ventricle of the heart. You get ventricular excitation, followed by ventricular systole, which is ventricular contraction. That's followed by ventricular diastole, which is ventricular relaxation. And then the process starts back over again here. So again, we talked pretty much about the graphic in the bottom right, maybe with the exception of the RR interval and the QT interval. The RR interval is simply the interval between each QRS complex, or each R and R complex, and that's what we use as the ventricular heart rate. That's how fast your pulse is, essentially. QT can also be helpful in certain disease conditions, and we'll talk briefly about that later. In the upper left, there's just a segment of EKG paper, and the graphic talks about what each of those little segments mean. For example, here on the horizontal axis, that has to do with time. The horizontal axis is time. The vertical axis is voltage. We're talking about the horizontal axis. Each small box is 0.04 seconds. Each big box is 0.2 seconds, and that's because the big box is composed of 5 small boxes. So there are 1, 2, 3, 4, 5 small boxes in each big box. 0.04 times 5 is 0.2 seconds. Horizontally, we measure in millimeters. You'll hear about millimeters of ST elevation. Each one of the small boxes is equivalent to 0.1 millivolts. When we talk about rate, we can get a pretty good idea of what the heart rate is by measuring the number of large boxes between either atrial or ventricular contractions. For the most part, when we're talking about the rate, we're talking about the ventricular rate, not so much the atrial rate. So if you have a QRS complex that starts here at this solid black line, and the next one is at the next solid black, is one big box away, that gives you a heart rate of 300. If it's 2 big boxes away, so you have a QRS complex here and another QRS complex here, that's heart rate 150. If there are 3 big boxes between QRS complexes, heart rate's 100, 475, 560. So the other way you can do it is you can count the number of big boxes and take 300, divide it by the number of big boxes. So let's just say, you have one beat here and your next beat's here. That gives you 5 big boxes between. 300 divided by 5 is a heart rate of 60. So you can either memorize, 300, 150, 100, 75, 60, 50, or you can just memorize 300 divided by the number of big boxes between QRS complexes to give you the heart rate. Remember that a standard 12-lead EKG is a 10-second strip. The bottom 1, 2, or 3 lines will be a full rhythm strip, a full 10 seconds long. The upper 3 lines are cut into 2.5 second intervals, and I'll show you that more with a regular EKG in a minute. Better explain that. Again, large boxes are 0.2 seconds, small boxes are 0.4 seconds, 5 small boxes in a big box. Amplitudes measured in millimeters, intervals are expressed in seconds. So we usually talk about how many millimeters of ST elevation. And this better explains the previous slides here. If you take a look, the top 3 strips are cut into 2.5 second intervals. So between here and here is 2.5 seconds. This between here and here is 2.5 seconds. Here and here is 2.5 seconds, and here and here is 2.5 seconds. So the whole strip is 10 seconds long, and that's the bottom 3 here are 10-second rhythm strips, whereas the top 3 are cut into 4 2.5 second smaller strips. And again, for time reasons, a tiny box is 0.04 seconds, a big box is 0.2 seconds. And then this doesn't really talk about amplitude, but amplitude's measures in millimeters. When we talk about EKG interpretation, generally we're going to talk about the rate, the rhythm, the axis, hypertrophy, or infarction. A rate we typically will talk about, is it a sinus rhythm? Is it tachycardia? Is it bradycardia? Rhythm, is it regular or irregular? Axis, is it left, right, or normal? Is hypertrophy present or absent? Infarction present, absent, or maybe it's an imposter, and we'll talk about each of those. There are 2 possible rates we can look at. One would be the atrial rate, which is measured by the P waves. The second is the ventricular rate. Ventricular rate is what correlates with the pulse that you feel when you do an exam. You hope that the atrial rate and the ventricular rate are the same. That's what it should be, but there are plenty of disease states where the atrial rate and ventricular rate are different. So let's take a look at this top strip here. First, we want to look and see, it looks like there's a P wave in front of every QRS complex, and it looks like it's pretty regular. We talk about the rate. The rate is going to be essentially the time between the two QRS complexes. Let's find a QRS complex that lines up directly on one of the big boxes. Here's one right here. And if we count the number of big boxes, we get 1, 2, 3, 4, 5. 300 divided by 5, so this heart rate's a little less than 60, since there's slightly more than 5 boxes between the two. You can also use the 300, 150, 100, 75, 60, if you've memorized it that way. So heart rate is just less than 60. There's a P in front of every QRS. Looking at the bottom strip here, obviously this is significantly faster. Looks like there's a P wave in front of every QRS complex, so the atrial and the ventricular rate is going to be the same. If we want to get the exact heart rate, again, pick one of the QRS complexes that lines up directly on one of the big boxes. This one's pretty close, so we get 1, 2, 3. 3 boxes here. 300 divided by 3 is about 100. It's just less than 3, so slightly over 100 was what I would say the heart rate is. All right. What's this? Looking at the top strip. Again, if you take a look at this, really don't see a P wave. If we want to figure out, it looks pretty regular. Doesn't look like there's much change in the interval between the RRs. So it's rapid, regular. I don't see a P wave. So it's some type of an SVT probably. If we want to get the ventricular rate, here's one that lines up pretty close to one of the big boxes, and so we see 1, just less than 2, so heart rate's just over 150. So it's probably SVT, heart rate around 160 or so. So if we want to treat that, probably going to give the patient adenosine. Now let's take a look at the second strip. What we notice here is there's a significant change in the strip. At least this side of the strip, the left half of the strip is significantly different than the right half of the strip. What we see here is we see a P wave, a QRS, a T wave, a P wave, a QRS, and then we see this here, this beat here. If you take a look, what is this beat? This beat is most likely a PVC. Well, it looks like you go from sort of a sinus bradycardia, have this PVC. Once you have the PVC, you're in a much more rapid rate. So more than likely what's going on here is this PVC has set up a reentrant pathway. So you go from a normal or a sinus bradycardia on this side of the strip to a reentrant tachycardia on this side of the strip. And the reentrant tachycardia is initiated by this PVC that sort of hits right after the T wave. So if a PAC or a PVC hits just the right time and the normal conduction pathway is still refractory, you can get conduction through a fast AV nodal pathway and end up with a reentrant tachycardia. And here's another example here. If you take a look here, really can't see much in the way of P waves, at least before the QRS complex. If you want to take a look at the rate here, here's one that falls on one of the big boxes, so a little less than 2 boxes, so heart rate's probably about 170. So reentrant tachycardia, regular rate, heart rate's 170. Again, we're going to probably treat this with adenosine. So here's a short video that talks about the anatomy in the heart. You can take a look at this link at your leisure. And again, talking about the electrical conduction system in the heart, the sort of a review slide. The pulse starts or the heart rate electrical pathway conduction starts at the SA node, depolarizes the atria, kind of gets slowed down in the AV node before it extends through the bundle of His and the bundle branches located in the ventricle. Finally, it goes out through the Purkinje fibers that depolarize the remainder of the ventricle. Following depolarization, you get repolarization. The repolarization is the T wave. The depolarization is the QRS. So depolarization of the atria is the P wave. Depolarization of the of the ventricle is the QRS complex. Repolarization of the ventricle is the T wave. So when we talk about heart rhythms, we again talk about whether they're regular or irregular. And then we want to think about, is it an atrial rate, a nodal rate, or a ventricular rate? Well, the next question is, and how do you, regular, irregular is pretty easy to tell. I mean, you just look at each QRS complex, and if there's a normal or symmetric space between each of those, well, it's pretty regular. If each QRS complex is a different amount of time between the next one, it's irregular. To decide if it's atrial, nodal, or ventricular, well, typically we can kind of use the heart rate to decide on that. You know, if it's atrial initiated, heart rate's going to be sort of in the 70 or more range. If it's nodal initiated, it's going to be more of a heart rate of 50. If it's ventricularly initiated, heart rate's going to be around 30. So when we talk about this is a regular rhythm. What we mean by that is the time between each QRS complex is very similar from beat to beat. There's a P wave in front of every QRS complex, so this is a regular rhythm. Here's an irregular rhythm. If you take a look at this, the distance between this QRS complex and the next one is different. The next one is different from that. This one's even shorter than any of them. Then it lengthens back out again, it gets short again, so it's irregularly irregular. And if you want to take a look, it's hard to say if there's any P waves. I mean, maybe there's one here, maybe there's one there. But this is probably more of an atrial fib, maybe a couple flutter waves mixed in there. Now, if we take a look at this strip here, you'll notice that it is also irregular. The distance between each QRS complex is different from beat to beat. What you'll see here is a very clear kind of this sawtooth pattern, which is what you'll typically see in atrial flutter. So this is atrial flutter. And here's more of a atrial rhythm. There's a P wave in front of every QRS complex. The rate's very regular. So what about this strip? Is this an atrial rhythm? Again, we don't have all of the leads here. We're only given a few of them. And, you know, if we ignore the fact it looks like there's a inferior STEMI going on, the inferior STEMI, if you take a look at this picture of the coronary arteries, there's a big clot in the right coronary artery. Well, the right coronary artery will frequently perfuse the conduction pathways through the heart, and so you may end up with some blocks. When we look at this strip, might see a P wave occasionally, but it really does not look like the P wave, the atria and the ventricles are communicating well at all. So it looks like this is third degree block, and you can tell that it's a ventricularly initiated rhythm because of how slow it is. You know, if we count the number of big blocks between the QRS complexes, we get 1, 2, 3, 4, 5, 6, you know, over 6, so heart rate's in the 40s, and that's going to be typically a ventricularly initiated rhythm, or some type of a low nodal rhythm. So here's another EKG to take a look at. If we take a look at this strip, is it regular or irregular? Well, obviously it's irregular. The distance between each QRS complex is different. It's fairly long here, gets a little shorter, even more short, and it starts to lengthen back out again. But we do see a P wave in front of each QRS complex. And if you take a look at the P wave, it looks very similar. I mean, it looks like the same kind of P wave. If I told you this was a child, um, then sort of give this away. This is what we call sinus arrhythmia. Sinus arrhythmia is an irregularity, which is probably caused by breathing. When kids breathe in and out, it can stimulate the vagus nerve when they breathe to make their heart rate slow down and speed up. So you'll see arrhythmia, but the P waves will look the same. Or arrhythmia, as in it's irregular, but the P waves look pretty much the same. Here's an example of a nodal rhythm. This is actually a junctional escape rhythm, and what you see is some retrograde conduction. And what I mean by that is, if you think about a few slides back here when we talked about the normal heart rate starting in the SA node and extending down through the AV node and then to the ventricles, what's going on here is you have the QRS complex starting at kind of low in the node, and when it does that, it actually goes back up to the heart. So instead of coming down from the SA node into the node, it starts at the node and goes the opposite direction back up to the SA towards the SA node, and that's why you see what we call an inverted P wave. The P wave's upside down. That's because the electricity is starting at the AV node and going back up towards the atrium, so it's going in the wrong direction. Anytime electricity goes in the wrong direction, it causes the P wave to go the wrong direction, makes it upside down. And then from there, electricity, there's again a little pause as it finishes through the AV node, and then you get your QRS complex. So you got a very slow rhythm here with an upside down P wave. So that's what we call a junctional escape or low nodal rhythm, retrograde conduction through the atrium at least. And here's another EKG for you to take a look at. Give you just a second to look at it. So, regular or irregular? Well, it looks like the QRS complexes are pretty regular, but really, really slow. There's 1, 2, 3, 4, 5, 6, 7, 8, boy, about 9 big boxes between QRS complexes. I'm not really sure what 300 divided by 9 is, but you know this is a 10-second strip, so we can go 1, 2, 3, 4, 5, 6 beats here. 6 times 6 is 36 because it's 10-second strip. So there'll be 10 of these, basically 10 of these strips in a minute, and there's 6 beats on here, so 6 times 6 is 36. So very slow ventricular rate. When we look at the atrial rate, well, it looks like there are this P wave, probably a P wave here in this T wave, another P wave, P in the T, P wave, P in the T, P. So it looks like the atria and the ventricles are not talking to each other. And the atrial rate is, significantly faster, 300, 150. So atrial rate's probably about 100, but the ventricular rate's only in the 30s. So this is third-degree heart block. And you can kind of tell that because of the fact that it appears that the P waves and the QRS complexes are not talking. You get this wide QRS, which is pretty typical of a ventricularly initiated QRS complex. So when the contraction in the ventricle is initiated in the ventricle, then the QRS complex tends to be pretty wide. Here's another example of a ventricular rhythm. Now this is a lot faster than what we talked about before. And give you just a second to look at it. And this is torsades, where you get these big QRS complexes that are wide, but they change. Torsades means twisting of the points, which basically means that the QRS complex goes from large to small, back to large to small. Here's another EKG for you to take a look at, or just a little rhythm strip. Notice here, fairly normal QRS complex, maybe a little bit wide, and then something changes here, and then, the right side and the left side look fairly similar. It's just in the middle here that's different. And what you notice here is what we call a run of E-tack, a 5-beat run of E-tack. There are these 5 beats that are very similar in appearance that fall in the middle of the EKG strip. So this is a little run of E-tack. When we talk about EKG interpretation, just some general guidelines here is most rhythms that are regular are going to be things like sinus, although we did see the sinus arrhythmia there with the child breathing in the one EKG strip we reviewed a few minutes ago. Reentrant tachycardias are usually fairly regular. V-tach is regular. For rhythms that are mostly regular are going to be things like sinus with PAC. So most of the beats are going to be normal, but then when you get the PAC, it's going to become irregular for one beat. If you get a PVC, it's going to be irregular for one beat, unless you have multiple PACs or PVCs. Then you may see more than one irregular beat. Atrial flutter can be regular if the block between the atrium and the ventriculars is regular. So if you're, an atrial flutter, your heart rate's, atrial rate's 300, and you have a, 3-to-1 conduction, then your ventricular rate's 100. It's pretty regular. If the block is variable, and sometimes it's 3 P waves to every QRS, and then sometimes 4, then you're going to get an irregular rhythm with the rate being either 100 if it's a 3-beat block. If it's 4 beats between each QRS complex, it's going to drop down to 75. So atrial flutter could be mostly regular or it could be irregular. And then other irregular rhythms would be AFib, VFib, torsades. Let's talk a little bit about axis. The axis basically means the major direction, or the direction that most of the electrical activity is headed towards. So it starts in one area of the heart and extends, for the most part, from the right upper heart to the left lower heart. And that's normally how it goes. It starts right upper and goes to left lower. That's how. So the axis is the major direction. It's the direction of most electrical. If you average it, it's sort of the vector. It's where most electricity starts and goes towards. When we talk about vectors or axis, it can be either normal, left axis, which you might see in left axis. We talk about left axis deviation. That's when the axis is towards the left. It can be rightward, or it can be indeterminate, and we'll show you that in the next slide here. So this is what we call normal axis. If you go back to one of the first few slides in the heart of the heart, we're talking about the way that electricity travels normally through the heart. If you kind of put the heart behind this being the right side of the heart, right upper heart, right atrium, and this being the left ventricle, majority of the electrical pathway starts in the right upper and heads towards the left lower part of the heart. So that's why normal is in this range here. So if most electricity goes between minus 30 degrees and 90 degrees, then that's normal. If most of it heads over in this side, you get right axis deviation. If most of it heads kind of upwards in this direction, you get left axis deviation. And we'll talk more about that in the next slide or two to make this clear, because I know it's not clear yet until we actually talk about how you determine axis in different leads. So this is helpful. This is sort of the previous slide, this circle with the different leads listed, at least the limb leads listed. So this has, AVF is the same as 90 degrees, AVL is the same as minus 30 degrees. So when we look at axis, we expect axis to be positive in AVF and positive in and positive in AVL, because that's going to give you what we call a normal axis. What do we mean by positive? Well, positive is the direction of the majority of the deflection of the QRS complex. So if you take a look at lead 2 here, the vast majority of the deflection is upright, which is positive. In order to determine axis, we want to see positivity in lead 1 and in lead AVF, or at least AVL and AVF. So if you take a look at lead 1 here, majority of the QRS complex is positive. In AVF, the majority of the complex is positive. So this is what we call a normal axis. So in left axis deviation, instead of the main deflection being down in the lower left part of this picture, the majority of the deflection is in the upper left side of this picture. What does that mean exactly? Well, that means that instead of your heart, the main electrical pathway starting in the upper right of the heart and going down to the bottom left, it's actually heading towards the upper left side by looking at the leads. Just to try to explain that a little bit better, it means that when you take a look at your EKG, instead of being positive in lead AVL and positive in lead 3, you get a net negative in AVL, but still positive. A net negative in lead 3 and positive in AVL. And that basically means that the main vector of electricity through the heart is actually headed more upwards to the left side. Now for right axis deviation, that means the main electrical vector starts in the upper part of the heart and heads more down towards the right lower part of the heart. And as we talked about before, the main electrical vector should go towards the left lower part of the heart. In right axis deviation, it heads towards the right lower part of the heart. So what does that mean? If it's headed towards the right lower part of the heart, that means it's going to be positive in AVF, as it should be with normal axis, but it's going to be net negative in lead 1 or negative in AVL. So in this one, if you take a look at the complex here, it's more negative in lead 1 and more negative in lead AVL than positive. So it's going the wrong direction in lead 1 and AVL, but it's still correct in AVF. It's mostly going down. So since it's negative 1 AVL, it's headed more towards the right and downward as it should. So that's right axis deviation. And here's an example of indeterminate. This means the QRS, the main electrical pathway, is headed upwards and towards the right side. And that's going to give you a negative in lead 1 and a negative in AVF. So a negative in lead 1 and a negative in AVF. So this is, sort of looks like a VTAC type strip. And it's negative in lead 1, negative in AVL. And negative in AVF, I'm sorry. Let's talk just a little bit about intervals. Specifically the QT interval. There are lots of different ways to say whether the QT interval is normal or not normal. A fairly simple way is if the QT, which is the distance between the Q, which this EKG doesn't really have a Q, so you start at where the R wave begins, and the T wave. So that's the Q to the end of the T wave, or beginning of the R to the end of the T wave. That's the QT interval. If the QT interval is more than half of the RR interval, well, that's abnormal. Long QT can start from several different medications. It can come from hypocalcemia, hypokalemia, low magnesium. So these are all disease states that can lead to long QT syndrome. If you want to get really academic, you can review this slide that talks about how you can more precisely determine what the QT is. When QT gets long, it does increase your risk for arrhythmias. Next thing we want to talk about is hypertrophy. Hypertrophy basically means a thickening of the heart. If you think about your heart's a muscle. When it pumps against really high blood pressure over years and years, what happens to the heart? It gets thicker and thicker and thicker because the heart has to get stronger to pump against this high pressure. When the heart gets thicker, that's called hypertrophy. When a muscle is thicker, it takes longer for electricity to pass through. So you get a taller QRS complex. because the QRS complex represents ventricular depolarization. So you get this tall QRS because there's more muscle and it takes a little longer for electricity to pass through. There are multiple different ways to decide if a patient has LVH. We have two criteria listed here. First is Cornell criteria. That's basically when you add the R wave in AVL to the S wave in V3. If the sum's greater than 28 and the patient's a male, then you have LVH. If it's greater than 20 in a female, you have LVH. Modified Cornell basically looks at the R wave in AVL. If the R wave greater than 12 millimeters, then the patient has LVH. So you don't have to add anything with modified. It's just looking at the R wave in AVL. So again, if we use the modified criteria here, you see that in AVL, the QRS complex is, or the R wave is, let's see, that's 5, 10, 13, probably 18 millimeters in AVL. Well, that's greater than 12, so they have LVH by modified. If you want to look at the R wave in AVL and the S in V3, so that's, like we said already, 5, 10, 15. S in lead 3, well, that's 5, 10, 15, 20. Gosh, it's hard to even say. I mean, you add the two together, it's 35, 40. So certainly more than 28. So LVH by either criteria. Here's another case. R wave in AVL definitely is not more than 12 millimeters in this case. But if you just take a look at the S wave in V3, it's 5, 10, 15, 20, it's 25 or 30 millimeters. So just by itself, without even adding to the R wave and AVL, you're at LVH criteria. The problem with LVH is you can get several different things. This is an example of LVH with strain. What that means is a strain pattern is this kind of scooped out or ST depression you may see, and in this I see it in multiple leads. You see it in 2, 3 AVF, you see it in lead 1, you see it in leads of V4 through V6. So that's kind of the strain pattern, this kind of scooped out ST depression, reciprocal T waves, etc. And you will see that sometimes in patients with LVH. That makes it hard to determine whether or not they're having a STEMI. So this is one of the STEMI imposters. And this EKG is an example of LVH with strain. Here's another partial EKG. You have all the precordial leads. What do you think about this EKG? Worrisome? Not worrisome? Well, in my opinion, you have this kind of deeply symmetrically inverted T waves, at least in V4, 5, 6, and sort of biphasic T wave in lead V3. In my opinion, this is fairly worrisome. Whenever you see kind of symmetrically inverted T waves with some ST depression, you have to think a little bit about ischemia. Not necessarily a STEMI, but maybe someone who's heading towards that direction. Maybe someone who's got profoundly high blood pressure. And again, here this patient may have just this tiniest little bit of ST elevation in these leads. Hard to say exactly what that means without the rest of the tracing. When we talk about infarction, how do we define infarction? Well, most books define infarction as 2 millimeters of ST elevation in the contiguous precordial leads, or 1.5 millimeters of ST elevation in the contiguous precordial leads in a female. What does contiguous mean? Contiguous just means leads that are side by side or look at a similar area of the heart. So contiguous leads in the precordium would be V1 and 2, or V2 and 3, or V3 and 4, or V 4 and 5, or V5 and 6. Any of the leads that are side by side. The other way you can diagnose an infarction would be greater than 1 millimeter of ST elevation in the other leads, non-precordial leads like 1 in AVL or 2-3 in AVF. Generally, in infarction, you're going to see something called reciprocal changes. Reciprocal changes are ST depression in leads that are sort of in the opposite direction of the leads you see in the STEMI. So what I mean by that, for an inferior STEMI, so you have ST elevation in the inferior leads. The opposite leads tend to be leads 1 in AVL, and you'll see ST depression there. For a lateral STEMI, which is leads 1 and AVL, or possibly V5 and 6, you may see ST depression in the inferior leads because those are sort of the opposite leads to the lateral leads. For an anterior STEMI, like in leads V2, 3, and 4, there's not any real reliable reciprocal changes that you'll note. If you do a posterior leads, you could see reciprocal ST depression if you put posterior leads on a patient. But with a standard EKG, you're not going to see reciprocal changes with most anterior STEMIs. An inferior wall MI occurs when there's an infarct in the inferior part of the heart. The inferior part is supplied by the right coronary artery. Occasionally, when the patient has a really large right coronary artery and the MI extends inferiorly, it can also go into the posterior wall, so you may get inferior and posterior STEMI. You may notice this repeat EKG from earlier in the talk. Here you have this clot in the right coronary artery, and you see, 1, 2, 3, maybe 2 millimeters of ST elevation, at least in lead 3, and you see this reciprocal change in 1 in AVL. So this is inferior ST elevation with ST elevation in 2, 3 in AVF, with reciprocal changes 1 in AVL. So this is a STEMI. And then in addition to that, you see third degree AV block. Another EKG to take a look at. If we ignore the STEMI and just kind of talk about the EKG in general, is it regular or irregular? Well, it looks pretty regular. The distance between each QRS complex is pretty regular. Is there a P wave in front of each QRS complex? Yes, P, 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 P. So we take a look at the heart rate. You got, if you find one of the QRS complexes, it's pretty close to one of the big boxes. There's 1, 2, 3, 4, 5, 6. 300 divided by 6 is 50, so heart rate's just less than 50. And then looking at our QRS complex, it may be slightly widened here, but not bundle branch wide. And then you see ST elevation in the inferior leads with reciprocal changes in 1 in AVL. So inferior MI. Another example. Give you just a second to take a look at that. So again, if we ignore the STEMI and just sort of follow our baseline rules for looking at the EKG, first we see that it's pretty regular. The distance between the QRS complexes is pretty regular. There's a P wave in front of every QRS complex. When we take a look at the heart rate, we'll notice there's 1, 2, 3, a little bit more than 3 boxes, so heart rate's just less than 100, probably in the 90 range. Again, there's a P in front of every QRX, so regular rate, sinus rhythm, heart rate in the 90s. QRS complex is fairly normal in width, and then we see this big ST elevation in the inferior leads. We also will see some ST elevation in V4, 5, and 6, reciprocal changes in 1 in AVL, so inferolateral myocardial infarction with reciprocal changes noted. May even see some reciprocal changes in V1 and V2 on this EKG. brief anatomy lecture here. You have blood coming out of your heart through your aorta. You have the right and left coronary arteries coming off of the aorta. The right coronary comes down and supplies the inferior part of the heart, and it supplies the right ventricle, and comes around and supplies the posterior part of the heart. The left main splits into the circumflex and the LAD. LAD supplies the left side of the heart, and the septum. Circumflex kind of goes around and supplies more of the posterior part of the left side of the heart as well. And in this picture here, you see that the right coronary supplies the inferior wall. So when you have a right coronary, you're going to see 2-3 and AVF, ST elevation. Video for you to watch that talks about the importance of reciprocal changes. Pretty good video. I recommend it. So let's talk about anterior wall myocardial infarctions. Here's only a couple leads provided here, V2 and V3. When you take a look at these leads, you see there's this pretty impressive 5 millimeters of ST elevation. This is kind of what we talk about sometimes as being tombstoning. The ST segment looks sort of like a tombstone at the top, kind of hyperacute with ST elevation. The anterior wall of the heart gets blood flow from the LAD, and so when there's LAD occlusion, then you get ST elevation in the precordial leads. And again, for anterior wall, you may see ST elevation in V2, V3, V4, 5. V3, V4 are the prominent leads, but you can see ST elevation, even throughout all the precordial leads, essentially, if it's a really large MI. And if you remember before, when you place, your leads around the heart, V3 and 4 are sort of in this region, and the electrical pathway of the heart starts in the right upper and heads down to the left lower. When you're having an MI in this region of your heart, V3 and 4 are sort of the camera that look directly in that part of the heart. So here's another example of an EKG. Let's review this EKG, similar methodology to what we've done before. Taking a look at it, distance between RR is pretty similar, so it's regular. It's P wave in front of every QRS complex. If we find one of these QRS complexes that sort of fall right on one of the big boxes, here's one that's pretty close. You get 1, 2, 3, 4. So the heart rate's in the 70s. Regular with a P wave in front of each QRS, so sinus rhythm, heart rate in the 70s. QRS complex is pretty normal in width. We talk about how wide the QRS complex should be. It should be less than 3 boxes, 3 small boxes, that is. So it's pretty normal. But when we look at this, we see ST elevation markedly in V4, V5. Maybe a little bit in V3, maybe a tiny bit in 1 AVL too. So this is anterolateral myocardial infarction. You may see a tiny bit of ST depression in 3 and AVF, which kind of goes along with the lateral part of the infarction. Again, remember, you don't tend to see reciprocal changes reliably in the anterior infarcts, but since this one extends laterally, you may see some reciprocal change in regards to the lateral part of the infarct. So a septal infarct tends to occur when you have a more proximal LAD lesion in LAD or a left main coronary occlusion. The septum is viewed best with leads V1 and V2. Again, remember that these leads are sort of your camera looking at the electrical pathway through the heart. Think about where you put your V1 and 2 leads on the patient's chest. It's right over the septum of the heart. And here's another EKG. With this EKG, we see, again, thinking about the way we're supposed to review these, it's regular. There's a P wave in front of each QRS complex. The QRS complexes are less than 3 small boxes, so they're normal. Then, obviously, it's hard to take your eye away from this, massive septal MI. There may be a little bit of a lateral infarct as well, at least AVL. There's elevation, maybe not any elevation in one. You do see some reciprocal changes here in the inferior leads, which you don't necessarily have to see with a septal infarct. So, large infarct needs to go to the cath lab. Another EKG, again, trying to ignore the MI and review the EKG the way that we should. You see that it's a regular rhythm, looking at all the QRS complexes. There's appears to be a P wave in front of every QRS complex. Heart rate is 300, 150, about 100. QRS complex is less than 3 boxes wide, so a normal QRS complex. There's this massive ST elevation in V2, V3, V4, some in V5 as well. So very large infarct, may actually be some Q waves already in V1 through V4, so it may be going on for a bit. So anteroseptal infarct here, both the anterior part of the heart and the septum involved. When we talk about a pure lateral infarction, lateral infarctions, the lateral part of the heart, so we're talking about over in this region. If you want to know how to look best at the lateral wall, you want to have your camera here, which is where leads 1 and AVL are located. So 1 and AVL tend to look best at the lateral part of the heart. And here's an example. You have pretty impressive ST elevation in leads 1 and AVL. V5 and 6 also look fairly lateral. They look anterior, but they also look lateral because they're pretty far around on the lateral side of the patient. So you get ST elevation 1, AVL, V5, and 6. In this particular EKG, there's reciprocal changes in the inferior leads, at least in leads 3 and AVF. So lateral MI. Here's another EKG example. Again, just thinking back about the way we're supposed to review these. Heart rate's regular. There's a P in front of every QRS complex. QRS complex is narrow, less than 3 boxes wide. Heart rate is, here's one that falls right on a big box. So 1, 2, 3, 4. So heart rate's about 80 or so. And then looking for our ST elevation, you see pretty impressive ST elevation starting in lead V4 and going through V6. Well, 1 in AVL, not quite as impressive in this EKG. So sort of anterolateral myocardial infarction. No reciprocal changes really seen here. Posterior wall of the heart. When we think about posterior wall, that's kind of on the back side of the heart. It tends to be more on the right, more of the right ventricle. The left ventricle, the heart sort of rotates a little bit in the chest, so left ventricle is more anterior, right's more posterior. When we look at for a posterior MI, the way we diagnose that on EKG is generally by ST depression noted in V1. Oftentimes in the ED, when we print one of these EKGs, we'll flip it over and look at it upside down, and you'll see marked ST elevation in lead V1 if you flip it over. But just looking at it or looking at it on the monitor, you're going to see, a couple millimeters, 1 or 2 millimeters of ST depression in lead V1. That's how you diagnose a posterior wall MI. So again, remember, inferior MIs are best seen in leads 2, 3, and AVF. Septal MIs are best seen in V1, V2, maybe V3. Anterior, somewhere between V2 and V5. V3 and 4 are best. Lateral 1, AVL, V5, and V6. Let's talk briefly about imposters. An imposter is obviously going to be something that looks like something that's not. When we're talking about imposters for MI, we're talking about something that looks like a heart attack but really isn't. couple of imposters here. So here's a list of STEMI imposters: left bundle branch block, pericarditis, left ventricular aneurysm, subarachnoid hemorrhage, LVH, Brugada syndrome, benign early repolarization, hyperkalemia, and paced rhythm. I'll speak briefly about each of these. To start with, let's talk about what is a STEMI and what's not a STEMI. When we talk about a STEMI, we're talking about elevation of this J point. The J point is where you kind of convert from the QRS part of the EKG into the T wave. When that's elevated, it's either J point elevation from a STEMI or from some other cause. So we really need to focus on this ST segment here, starting at the J point and extending to the T wave. That's kind of crucial in deciding if it's a STEMI or not. You may see broad, asymmetrically peaked or kind of hyperacute T waves in an early MI. Oftentimes that'll precede ST elevation and precede the Q waves. Q waves are a late finding with an MI. So we progress from ischemia to injury to infarct, and each of those look a little different on the EKG. So we'll talk about each one of those briefly. So ischemia basically is lack of oxygen. When you get lack of oxygen, you get kind of ST depression or T wave inversion. You may see, any of these type of ST depressions with ischemia. With injury, that's more of a progression from just not getting enough flow to actual damage to the tissue. When you get this damage, you see ST elevation on your EKG. Once the injury has progressed to an infarct, death of tissue, then you get a Q wave. A Q wave is a downslope before the RS wave. So that's what the Q is in the QRS segment. In general, you don't see much of a Q wave unless there's been a heart attack in the past. When you have certain injury patterns, you may see reciprocal changes. We take a look here, oftentimes anterior septal or anteroseptal, you may not see any reciprocal changes. When you have a lateral injury pattern, a lateral MI, which would be ST elevation in leads 1, AVL, possibly V5 and 6, you'll oftentimes see reciprocal changes in 2, 3, and AVF. When it's anterior lateral, which is 1 AVL, V3 through V6, you may see reciprocal changes in the inferior leads 2, 3, and AVF. When you have an inferior MI elevation in 2, 3, and AVF, then you'll see reciprocal changes in 1 and AVL. If you have a posterior MI, well, you don't see ST elevation. Remember, we talked about that. You see ST depression in lead V1. But you may see some reciprocal changes. That's the depression we're talking about, and leads V1 through V4. So for the inferior leads, reciprocal are the high lateral and anterior leads. For anterior leads, the reciprocal are posterior leads, which we usually don't place on patients. And then, you should always look for reciprocal leads to help you confirm ST elevation. And I hope that was the importance of reciprocal changes. Hopefully were discussed on the video that hopefully you've watched, the little YouTube video. So what do you think about this EKG? So it's regular, normal rate, regular rhythm. There's a P for every QRS complex. The QRS complexes are narrow. And then you see ST elevation marked ST elevation in the inferior leads, 2, 3, and AVF. You see reciprocal changes in the lateral leads, maybe a little bit of reciprocal change, or I shouldn't say reciprocal. It is reciprocal change, but probably a posterior MI as well, with changes at least in lead V2. What about this EKG? Give you just a second to take a look at that. So, again, trying to consider the rules that we have here for reviewing this. It looks pretty regular for the most part. I believe there are P waves in front of every QRS complex, but it's a little tough to say for sure on the P waves. Heart rate looks like it's, let's see here, 1, 2, heart rate's a little over 100. But when we talk about ST elevation, there's this massive ST elevation, V1, all the way through V6. There's ST elevation 1 AVL, and then pretty marked ST depression in the inferior leads. So this is definitely a STEMI. This is probably a left main with, the anterior part of the heart involved, the septum involved, the lateral part of the heart involved. So this patient definitely needs cath lab right away. So let's continue on with EKG interpretation part 2. This is March 2017. We'll start off by discussing STEMI imposters. So what are STEMI imposters? Well, they're imposters that show ST elevation, but there's no heart attack occurring. This makes it sort of difficult. I'd encourage you to treat your patient and not your monitor at all times, because anytime a patient's having chest pain and you think it's from their heart, then you should treat them that way no matter what their monitor shows. Here is a list of ST elevation MI imposters that we're going to talk about. The list includes left bundle branch block, pericarditis, left ventricular aneurysm, subarachnoid hemorrhage, left ventricular hypertrophy, Brugada syndrome, benign early repolarization, and a paced rhythm. Let's start with left bundle branch block. Well, how do you know if you have a left bundle branch block? In order to decide whether the patient has a bundle branch block, you have to measure the width of the QRS complex. If the QRS complex is greater than 0.12 seconds, that is criteria for a bundle branch block. What is 0.12 seconds? Well, 0.12 seconds, as I mentioned in the previous discussion, is 3 small blocks. So anytime you see a QRS width that's greater than 3 small blocks, especially if you notice it in V1, that's a bundle branch block. When you take a look at lead 1, that's the normal lead we use to decide whether it's a right bundle branch block or a left bundle branch block. So if the QRS is greater than 0.12 seconds, again that's 3 blocks, and it's positive deflection, so if the net is upright in lead V1, then it's a right bundle branch block. If the net deflection is left, then it's a left bundle branch block. So here's an example. If you take a look, if you want to read these as we normally read them, again, looks like it's a pretty regular rhythm. There is the same spacing between each QRS complex. Again, a little bit hard to see P waves, but I think in lead 2 you can see P waves before each QRS complex. So it's a regular atrial rhythm, and the heart rate is approximately 300, 150, a little bit over 100. When we take a look at the QRS complex, when we take a look in V1, clearly more than 3 small boxes, so more than 0.12 seconds, which is a bundle branch block by definition. The net QRS deflection is downward in V1. If the net was upright in V1, that would be a right bundle branch block, but since it's downward in V1, that's a left bundle branch block. With left bottom branch block, you'll see more of a net upright in V6. Here's another example down at the bottom. Take a look at this EKG strip. Again, using our normal way of reviewing these, you see that it's pretty irregular. The distance between each QRS complex is variable. You go here and then wider, then narrower, then narrower, then narrower, and then sort of narrow here and then widen again. So, but it looks like it's pretty irregular in general. I don't really see any P waves in front of the QRS complexes, so I'd say this is probably atrial fibrillation. Heart rate is somewhere between upwards of 150 down to as slow as maybe 100 to 150 would be my reading on it. When we take a look at the QRS complex, take a look in lead V1, definitely more than 3 small boxes. The main deflection in V1 is upright. Sometimes you'll see a little rabbit ear, but anyway, when the main deflection is upright in V1, that's called a right bottom branch block. So this is AFib with a right bottom branch block, rapid rhythm, rapid rate. Here's another one, and again, taking a look at it the way we should be reading these, it's regular. The distance between each QRS complex is the same. Looks like there's a P wave in front of each QRS complex, so it's a atrial rhythm. Heart rate is, if we use this one, 300, 150, 100, probably around 80. So sinus rhythm, heart rate of 80. Looking at the QRS complex here, definitely in V1 more than 3 boxes. The main deflection is downward. So this is a left bottom branch block. Now the reason why left bottom branch block makes it difficult to read an ST elevation MI is because when you have abnormal depolarization of your heart, it's going to affect the repolarization. So essentially what I mean here is if you look in V1, V2, V3, it takes a long time to depolarize the heart. By the time you finish depolarizing the entire ventricle, it started to already repolarize in other parts, so the kind of the QRS complex starts to run on top of the T wave. There's really not a lot of ST segment that's in the back to baseline. We like to say the ST segment should go back to baseline. Well, it can't really do that here because the QRS complex is so wide it starts to run on top of the T wave as a different part of the heart begins to repolarize. That makes it really difficult to read a STEMI because of the way this happens. The next STEMI imposter is called pericarditis. In pericarditis, you're going to see widespread ST elevation. Usually it's concave instead of convex, and I'll point that out to you on the EKG strip we look at in just a minute. You also see a lot of PR depression. There tends to be reciprocal ST depression and PR elevation in AVR. We don't talk a lot about AVR. In AVR, everything tends to be a little backwards of the other leads anyway. And that's the case in pericarditis. It's kind of backwards of everything else where you get the ST elevation and PR depression. In AVR, you get ST depression and PR elevation. Here's an example of pericarditis. So you get diffuse kind of ST elevation. I mean, if you look in the precordial leads, pretty marked ST elevation everywhere. 1 AVL elevation, lead 2 elevation, maybe not so much in 3 and AVF. You'd notice pretty impressive PR depression in V1, V2, all the way through all the precordial leads. Some PR depression in 1 and AVL for sure. PR depression in lead 2, maybe again not as much in leads 3 and AVF. When we talk about the ST segment, this is what I'm talking about as far as concave elevation. I mean, you get elevation, but you still get this kind of J, this fish hook or J. Here it doesn't. It's concave. It's not convex ST elevation. It's concave ST elevation. Another example here of pericarditis. Again, pretty impressive ST elevation. Pretty much everywhere. Same leads as before. Again, not so much ST elevation in 3 and AVF, but maybe some inverted T waves and so forth. Um, but again, you get impressive PR depression. When you look in AVR, you get PR elevation and ST depression, just as we talked about. You tend to see that with pericarditis. So anytime you see ST elevation sort of everywhere, think about pericarditis. The other thing about pericarditis is patients will typically have worse symptoms in certain positions. They maybe it'll tell you, hey, if I lay just like this, it doesn't hurt too much. But if I lean way forward, it hurts more. If I lay all the way back, it hurts more. So again, treat your patient. Consider your EKG, but treat your patient. Left ventricular aneurysm is another ST elevation imposter. With left ventricular aneurysm, you end up seeing left ventricular aneurysms typically occur after an MI. It's basically a big section of the heart that has died, and because that doesn't depolarize and repolarize correctly. And so you get ST elevation that is persistent, more than 2 weeks after an MI. It's most commonly seen in the precordial leads. The ST morphology is not necessarily helpful, could be convex or concave. Oftentimes you'll see a well-formed Q wave. Again, I say this follows an MI, pretty big MI, probably going to get a Q wave. I mean, Q wave usually means you've had an MI before. So let's talk about, let's see an example of this. So here is an example of left ventricular aneurysm. If you take a look at this, big Q wave, V1, V2, V3, and then you have this kind of ST elevation in these leads. A little tough to say for sure, is it an MI on top of an old MI, or is this an aneurysm? So again, this is really difficult to distinguish from a STEMI. The Q waves are helpful. An old EKG is very helpful. If it looks the same as what you've got today, then it's probably an aneurysm and probably not a STEMI. But again, I would say you have to treat your patient. If you think it's, if they're having acute crushing chest pain with shortness of breath and diaphoresis with this EKG, be tough to say for sure without an old one that it's not a STEMI. Subarachnoid hemorrhage, some intracranial processes can affect your EKG. Stroke, hemorrhage, carotid endarterectomy, you can see EKG changes. What you'll typically see is diffuse, deeply inverted T waves and maybe a little bit of a prolonged QT. So here's an example of an EKG post-intracranial hemorrhage. If you look over here in the precordial leads, V3 through V6, you see these deep inverted T waves. You see some inverted T waves in inferior leads, also in lead 1, so kind of diffusely inverted T waves. It may be that if you saw this, especially in the precordial leads, maybe not so much. If the limb leads look fairly normal, but you saw some precordial leads, you might be thinking it's ischemia. But if this is a patient with altered mental status, bad headache, certainly think intracranial hemorrhage. Here's an EKG of a patient, post-endarterectomy. Similar kind of event. You see these kind of deeply inverted T waves starting in lead V2 all the way through V6, and then also kind of diffusely in the limb leads as well. So consider intracranial processes when you see these deeply inverted T waves. Left ventricular hypertrophy. We talked earlier in the lecture about ways to decide whether or not a patient has LVH. And I mentioned there are lots of different ways or qualifications to have LVH. Here are several ways you can determine whether or not a patient has LVH. And I think we talked about adding the part of the EKG findings in the limb leads plus the precordial leads to get readings greater than, I think, 20 and 25 millimeters. And then we also talked about this R wave and AVL. But I'll let you take a look at these at your leisure to kind of, that way you'll know whether or not a patient has LVH when you look at their EKG. LVH is an imposter because when you have LVH, you may see ST elevation V1 through V3, you may actually see what we call a strain pattern, which is ST depression with T-wave inversions in 1 AVL, V5, and V6. Let me give you an example of what I'm talking about. So here we have LVH. You can take a look at those criteria from 2 or 3 slides ago to determine its LVH. I would say a quick and dirty way is if the QRS complexes overlap each other, on, say, if you take a look at this line and you take a look at the line below it, if they overlap, there's a pretty good chance you got LVH. So I know that doesn't necessarily, meet the criteria other than to say, there's, what is this, 5, 10, 15, there's over 20 millimeters between these to start with. So, you're going to have some part of your QRS complex greater than 20 some millimeters if they overlap. So anyway, they are overlapping here. And then what you see here is so you say this is LVH, and you see this kind of a strain pattern with a funny ST segment inverted T waves in V3 through V6. You see the same sort of inverted T wave in AVL. So this is LVH with the strain pattern. And that can be hard to distinguish between ischemia. I mean, it certainly doesn't look like a STEMI, but it can be hard to distinguish between an ischemic pattern. Here's another example, and here you actually do see in V1 through V3 ST elevation. Again, it's LVH because these things massively overlap. So you got many millimeters of your either here your S wave is, 5, 10, 15, 20, 25, 30 millimeters. So that meets criteria in any of those measurement criteria for LVH. So you got LVH, and this is the strain pattern with this kind of little bit of ST depression and inverted T waves in V5, 6, and in sort of in the inferior leads, and then with this LVH pattern here, you got some ST elevation. Very difficult to tell the difference between a STEMI and LVH with strain pattern. Brugada syndrome, probably won't see this very much. It's a congenital syndrome where you have abnormal sodium channels. The reason why it's important, you have increased risk of VTAC and VFib. Here's an example of Brugada syndrome. Because these abnormal, sodium channels, you get abnormal depolarization and repolarization. So you get this funny looking ST segment in V1, V2, and I think I have another slide that kind of talks more about the criteria for this. Increased risk of sudden death. You get sort of this incomplete right bundle branch pattern and ST segment elevations in the anterior precordial leads. There's 3 different types of Brugada syndrome. I'm not going to go through these individually because it's pretty rare. And here's what your EKG looks like. You have this kind of a little bit of a wide QRS complex, abnormal ST segments in type 1, type 2, and in type 3. So just something for you to take a look and review, especially if you get someone, a younger person who gets hit in the chest, and they're really having what seems to be musculoskeletal chest pain, and they have this EKG pattern. It'd be nice to be able to pick this up because you know that higher risk of sudden death. Most of these patients will get a pacemaker if it's picked up by cardiology. Defibrillator if it's picked up by cardiology. Benign early repolarization is also a STEMI mimicker. With benign early repolarization, you have this J point elevation. It's generally associated with, young patients that are physically active and have a fairly thin chest wall. Usually you see this concave ST elevation in the precordial leads, V2 through V6, and you may see it in the limb leads as well. And again, as I said before, this is usually young, healthy people. If you see this finding in folks over 80, be very careful. It's not nearly as common in older folks to see early repolarization. Here's an example of early repol. If you take a look at V2, V3, V4, you see this kind of little bit of ST elevation, but you got this concave ST segment. It kind of looks like a J. You also see it in the inferior leads as well. And here's another example of benign early repolarization. And here's a nice smiley face to help you kind of remember how this looks. I mean, if you take a look here, it looks like a J, or some people call it a fish hook. You got the smiley face here, nice concave ST segment elevation as opposed to convex. So young, healthy person, thin chest wall. Again, this might be the football player that got hit in the chest and is having chest pain afterward. It seems more musculoskeletal. Hyperkalemia. Elevated potassium can affect your EKG in lots of different ways. Initially you will see sort of peaked T waves, but as your potassium level rises, everything starts to slow down. So you get, increased PR segments, QRS complex gets wider, you may get some AV blocks, sinus brady, so everything starts to slow down after you get the peak T waves. So here's an EKG. So, at the onset of hyperkalemia, get these nice peak T waves that you see here, at least in maybe V2 and V3. There's a little bit of a delay in the QRS complex too, so the QRS complex is a little wider than it should be also. Now this is going to be sort of potassium probably 8. You get this kind of really wide QRS complex, and it'll kind of deteriorate from this to almost a sinusoidal type pattern pre-arrest, and then they arrest afterward. So be easy for this to be mistaken for some type of STEMI because it's so hard to see everything because everything's so wide. So dialysis patient, someone who's been vomiting, for days, looks dry, that sort of thing, consider hyperkalemia. Especially if the complaint is, I just feel weak, and I've had a lot of weight loss and don't know what's wrong with me. Consider hyperkalemia. Dialysis patients, always consider hyperkalemia. Paced rhythm. Paced rhythm is also a STEMI imposter. How do you decide if a patient has a paced rhythm? Well, you have to find these pacer spikes. The old pacemakers made it pretty easy for us because they had great big pacer spikes before their QRS complexes. The new pacemakers are better. The spikes are much smaller than they used to be. We have now pacemakers that will pace the atrium and the ventricles. So if you have trouble seeing it on the EKG, check your patient. If they've got a box under the skin in the left upper chest, they'd be pretty small now. I mean, some of these now are not a whole lot bigger than a quarter, thicker than a quarter, but not a whole lot bigger than that. Ask your patient, check their left upper chest. If they've got a box in there, there's a good chance there's a pacemaker present. So here's a couple EKGs. In this top EKG, obviously this is a pretty regular rhythm. QRS complex is very wide. Really don't see P waves, but you see these spikes in front of each QRS complex. These spikes represent a ventricular pacemaker. So really can't read a STEMI when you've got a ventricular pacemaker. Here's another example. Same sort of thing, although the QRS is not nearly as wide. It's regular. You see these nice linear spikes before each of the QRS complexes. So this is a pacemaker. So here's a little test. What I would encourage you to do is take a look at this EKG on your own time and see if you agree with the EKG reading. Really have to be careful in trusting what the machine says is the correct rhythm. I mean, you're the expert, not the machine, so be careful. Don't trust the machine. Here's the machine's reading, and I'd encourage you to kind of review these questions and see what you think. Here's another EKG. You see the reading at the top, AFib, PVCs, left bundle branch block. What do you think whenever you review this EKG? Is it really AFib? Well, let's take a look. And when we review this strip, it does look to be irregular. This is kind of a typical back of the ambulance driving down the road EKG, a lot of movement and so forth, but it is pretty irregular. I don't see any definite P waves, so machine may be correct about that. How about the QRS complex? What do you think about that? Well, if you take a look at the width of the QRS complex in lead V1, it doesn't appear to be more than 3 boxes. I mean, it may be a slight bit on the long side, but it's not long enough to be a bundle branch block, so definitely disagree with a left bundle branch block. I have a feeling this EKG machine is reading what's going on right here. And I ask you, what do you think is going on right here? What I'd say going on right there is most likely motion artifact, because if you take a look, V1, V2, and V3 are all recorded at exactly the same time. It's the same 2.5 seconds. In V1 and 2, you see this, funny wide complex stuff going on, but if you look at V3, it's not there. You should see the same thing in every lead. So since it's not present in V3, this is motion artifact. The machine reads EKG by signal averaging, so it averages everything it thinks is a QRS complex to get width. And because it's reading these beats here as ventricular beats, it's averaging them in with all the rest of the complexes, which is why it's reading it as a bundle branch block. If it was a bundle branch block, if you remember correctly, in V1, if the main deflection is upright, it's up, it's right bundle branch block, down is left bundle. So I guess since it's seeing these is going down here, it probably is trying to read it as a left bundle, but I disagree. I don't think it's a bundle branch block here. This is a fairly narrow QRS complex, and I believe this is all signal averaging, which is giving you the wrong read. So be careful. What's this? Well, this is the strip that we want to see on all patients that you guys pronounce as being dead. You want to see, asystole in more than one contiguous lead. What do you think about this? So what we see here is you got a regular rhythm, right? You've got a heart rate of 300, 150, 100, in the 80s, I would say. And then you've got the QRS complex is pretty wide. So wide complex rhythm. No definite P waves in front of each QRS complex. So essentially the reading is accelerated idioventricular rhythm. But from an ST elevation standpoint, really can't read this, right? Because if you take a look at your QRS complex, it's, over 5 boxes wide. So it's a bundle branch block pattern. And with a bundle branch pattern, we really can't read an ST elevation MI. What about this? Give you a second to take a look at it. So if we take a look at this, it's fairly irregular. Maybe the distance between these two beats is similar to these two and is similar to these two, but certainly there's differences all around that. So it's an irregular rhythm. I see P waves. It looks like there's a P wave in front of each QRS complex, but the P waves look a little bit different. So, these are basically atrial rhythm with PACs. And we don't have the rest of the leads, so we really can't talk about STEMI and so forth. Here are examples of atrial fib, flutter, and multifocal atrial tachycardia. With atrial fibrillation, the atria are essentially just quivering and sending rapid signal down to the ventricles. As the rapid signal goes through the AV node's refractory for good parts of the time, so the ventricular response will generally be much slower than the atrial rate. with atrial fib, your heart rate's going to be, greater than 300 in the atrial side, but the ventricular rate here is, quite variable. I mean, here it's, about 150 or so, but then over here, it's hard to say. It's less than 100 maybe. So that's AFib. Atrial flutter, you see these typical kind of sawtooth pattern of the baseline. It looks like an old handsaw. And then with each time you have a flutter wave, a signal sent to the ventricle through the AV node. But again, AV node is not going to let every one of those signals come through because it's going to be refractory a good part of the time. So here we have variable block. I mean, here we have one, two, three, four beats before there's a QRS. Here we have 1, 2, 3. So 3 to 1 or 4 to 1 conduction, it looks like, of the atrial flutter. For multifocal atrial tachycardia, what that means is there's multiple foci in the atria that are stimulating the heart to beat. So each one of the P waves looks different. If you look at this P wave, it's kind of wide and not too tall. Here this is a narrow one that's really tall. And here's one that's sort of biphasic. And then here's one that's kind of flat and biphasic. So you got lots of different looking P waves. This is pretty common in folks who have sort of end-stage COPD. When we talk about blocks, we have first degree, second, and third degree block. First degree block just means your PR interval's long. So the conduction through the AV node is much more slowed than it should be. With first degree block, there is still a P wave in front of every QRS complex. It's just the PR is long. So you see a P wave and a QRS. So there's a P wave in front, P and before every QRS. It's just the PR interval is much longer than it should be. In a second degree block, there's not a P wave. There's more P waves than there are QRS complexes. So you're going to have more P waves than QRSs. And so if you take a look here, you're going to see, P wave, P wave. It's P wave in here, P wave. If you get calipers out and you march it out, you'll see there's a drop beat periodically. So P, 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 no QRS. P, 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 no QRS. P, P. So this is a Winky-Bach type because your PR is getting longer every single time before it drops a beat. So your PR is short, gets a little longer, drops a beat. So with second degree block, most of the time there'll be a P wave before a QRS, but every now and then there's a P wave with no QRS because you have these non-conductive P beats. Again, for Mobitz type 1 block, which is also known as Winky-Bach block, you get this prolongation of the PR. It gets longer, longer, longer till you drop a beat. That's Mobitz 1. In this particular one, every other P wave is conducted. In Mobitz 2, that means your PR interval is actually pretty normal and doesn't appear to change in your beats, but then every now and then there's a P wave with no QRS. So that's Mobitz type 2. So the PR is the same here as it is here. Then there's a P wave with no QRS. And then if you look over here, there's a P, QRS, P, QRS, P, QRS, and a P, no QRS. But the PR is not increasing. The PR duration isn't increasing. So this is a type 2 block. And this Mobitz 2s are thought to be more serious than Mobitz type 1 blocks. Complete block means that the electrical pathway between the atria and ventricle is not complete. There's no communication between the atria and ventricles. And what you see with that is you just see P waves marching along and the QRSs aren't at all related. When you see that, if you remember from the beginning part of this lecture, ventricular rates tend to be sort of in the 30s, and I'll let you march this out, but it's a 10-second strip. There's 6 beats here, so this is a heart rate of 36. And then when you take a look at these P waves, they just keep right on going. They don't have anything to do with the QRS complexes. If you could do this long enough, you'd end up seeing a QRS on top of a P wave, that sort of thing. A little bit longer rhythm strip would make that clearer, but anyway, when you have a heart rate in the 30s, wide complex QRS, you know that this is a third degree block. So here's another EKG for us to look at. So when we take a look at this, we see that it looks fairly regular. Is there a P wave in front of every QRS? Boy, it's a little tough to say whether or not we see definite P waves. In lead 2, you might be able to see P waves here. It's a little bit tough to say. The QRS complex is pretty narrow. It's not a wide complex, so you think that it's coming from either atria or the node, higher in the node, since the QRS is pretty narrow. When you look at the axis, you're mostly positive in 1, positive in AVF, so it looks like it's a fairly normal axis as opposed to the computer reading of right axis deviation. And then we can take a look at the ST segments. I really don't see any ST elevation in this strip. So I think that concludes this part of the lecture.